I'm Tanya Fancher. I am a professor in the School of Medicine. I have to say, this is an incredible audience. I don't think that we've had folks from all of these different departments, schools, and divisions together before. So thank you all for coming. It's my pleasure to welcome you to our first event sponsored by the Center for a Diverse Healthcare Workforce. For those of you who don't know us, we are a HRSA-supported center, and really the work we do is to ensure that everyone in the nation has access to good care, they have access to the right doctors, and they're accessible in the right places. So the piece that we've focused on is workforce diversity, and we do that through research, through developing community connections, and also through dissemination. So today you're going to hear about one of the research projects supported by the center. Our focus has really been on admissions to medical school, as well as the role of community colleges in medical school admissions and health professions admissions. Microaggressions, which you'll hear about today, and our other project is looking at the experience of deaf and hard of hearing health professionals and what can we do to really support that community in health professions education. So I'm really happy to introduce to you Dr. Piri Ackerman-Barger. Piri is an assistant clinical professor here at the Betty Irene School of Nursing and is the new co-director for our center. So we are so pleased to be an interprofessional place, a truly interprofessional place, and think that many good things will come. Piri.
Yay, thank you, Tanya. Thank you all for coming. I have to say that I was a little bit nervous thinking about this, and as I'm looking out at all of you, I'm feeling excited to share our data with you. So I have some colleagues here that I am really excited to introduce to you. First, we have Dr. Darin Latimore. I think a lot of you know him already. Yay! He's the Deputy Dean and Chief Diversity Officer at Yale University School of Medicine. We also have Dr. Dowin Boatright. He is Assistant Professor, works in emergency medicine, Yale University School of Medicine. And we also have Dr. Rosana Gonzalez-Colaso. She's an Assistant Professor, Internal Medicine, Yale University School of Medicine, and she works primarily with PA students. So just a quick disclosure. The research we are sharing today was made possible through a HRSA grant called the Academic Units for Primary Care Training and Enhancement. So thank you very much for Tanya for writing that grant for us. So to get us started, I just want to start with the definition of microaggressions. I generally think of microaggressions as the outputs of our negative unconscious bias. More technically defined, they're the subtle statements and behaviors that unconsciously communicate denigrating messages to people of color. And we are focusing right now on folks of color. This can happen for folks from the LGBT community. It's not just racially, but we're focusing on that today. So there are different kinds of microaggressions, microassaults. So these are intentionally and explicitly derogatory verbal or nonverbal attacks. Nonverbal might be like eye rolling or not making eye contact or checking the watch multiple times. Micro insults are the rude and insensitive, subtle put downs of someone's racial heritage or identity, oftentimes in the form of a joke, followed by, oh, just kidding. And then micro invalidations are remarks that diminish, dismiss, or negate the realities and histories of people of color. A pretty common one is we're post-civil rights movement and racism is no longer an issue. Or we're all part of the human race type thing. So some things to know about microaggressions, they're not always consciously done, and some of the scholars will say that usually they're not done consciously. This is a byproduct of our unconscious bias. They're powerful because they're subtle, and they're sometimes invisible to people around us or the perpetrator, and that's what makes them so difficult. There's been some research that shows when it's explicit and it's clear, it's almost easier to deal with. But when you're wondering, what did that mean? What did they mean by that? How do I respond? That takes another amount of energy that is difficult to navigate. So the impact of microaggressions, Dr. Darin Sue is a prolific scholar on this topic, and what he says is that microaggressions cause mental health effects, primarily depression and anxiety. They create physical health problems that are likely secondary to that ongoing stress. They perpetuate stereotypes, right? That's problematic. And they passively allow society to devalue groups. They cause lower work productivity, right? And that is very significant in schools of nursing and schools of medicine. We don't want our students to have lower work productivity. We want them learning and performing. And they create inequities in places such as education, the employment realm, and healthcare. We have been very curious about this phenomenon and wanted to know, I mean, we had a pretty good hypothesis, but is this happening in schools of medicine and schools of nursing? And this is particularly problematic because the values that we have around health professions are not in alignment with the behaviors of microaggressions and unconscious bias, yet we're seeing patient outcomes that are a result of unconscious bias and microaggressions, right? So we wanted to see how often is this happening in schools of medicine, schools of nursing, and PA. So what we decided to do was a mixed methods study. So we had two complementary studies happening at the same time. So we looked at quantitative data through a survey, and Dr. Boatright has done a couple iterations of this. The first one was on a national sample of 832 medical students. We also did a sample from UC Davis, where there were 222 students total, 133 med students, 58 nursing students from across the nursing programs, and 31 PA students. The survey that he used was adapted from the racial and ethnic minority or ethnic microaggression scale and institutional betrayal questionnaire. And he did analysis through standard frequency and logistic regression model. For the qualitative, we talked to students across programs at UC Davis and Yale University. We used interview or focus groups, and we have done thematic analysis using in vivo.
So for our quantitative survey of microaggressions, our main goal was first just to identify what the prevalence and experience of microaggressions were among medical students. That being said, we were also interested in the impact of these microaggressions on medical students. In particular, one of our primary outcomes was wellness of medical students, which we'd measure with the PHQ-2 or the Patient Health Questionnaire 2, which is a very brief screening questionnaire for depression. Also, just some basic outcomes looking at medical school satisfaction. So again, to develop this survey, we adapted questions from the racial ethic microaggression scale that is a validated survey instrumented by Nadal. We adapted this survey to better reflect the academic medical center environment. We pilot tested these questions with medical students from the Student National Medical Association and the Latino Medical Student Association, in addition to focus groups with Yale medical students. We ultimately decided to incorporate 14 specific microaggressions that were identified most commonly amongst our focus groups. Some example of survey items are: people are surprised by how well I speak English. People mistake me for someone else who shares an aspect of my identity. People imply I was admitted to medical school for reasons other than academic merit. Faculty have discouraged me from pursuing medical fields that interest me. If a student selected any of these particular microaggressions and on a frequency scale greater than once a year, that person was then asked why they felt they experienced that microaggression. We used a variety of potential causes, including race, ethnicity, height, weight, skin color, ethnicity, sexual orientation, to help identify the root causes of these microaggressions as well. And again, for our outcome measures, we looked at the PHQ-2 for wellness and a variety of questions looking at medical school satisfaction. For our study cohort, we had 137 medical students, the majority of whom were women. Approximately 30% self-reported white race, 42% reported Asian race, and 8% black race, and approximately 12% reported Hispanic ethnicity. The median age was 26, and we have a reasonable distribution of medical school classes from years 1 through 4. Looking at the actual frequency of microaggressions, the reported experience is similar to what we'd anticipate based on previous literature, with approximately 50% of medical students reporting microaggressions at least either once a week or almost daily. Reasons reported for why microaggressions were experienced included gender, race, ethnicity, ancestry, skin color, socioeconomic status, height, sexual orientation, weight, and religion, with gender, race, and age actually being the most common reasons reported. When we looked at wellness, we performed a logistic regression model that actually divided the students into quintiles based on the level of microaggression frequency that they reported. As you can see, moving from the lowest quintile to the highest quintile, the likelihood of a student screening positive on the PHQ for depressive symptoms increased in a dose-respondent measure, such that students in the highest quintile were almost 7 times more likely to screen positive for depression than students who reported experiencing microaggressions in the lowest quintile. When we looked at measures of medical school satisfaction, we decided to divide our study cohort into 2 groups. Approximately 50% of students reported experiencing microaggressions at least weekly or almost on a daily basis, and we identified this group as the high-frequency group. Students reporting microaggressions less frequently were identified as the low-frequency group. When we asked very simple questions such as, I would recommend my medical school to friends, students in the low-exposure group were significantly more likely to recommend their medical school to friends than students in the high-exposure group. Likewise, students in the low exposure group were more likely to consider their current institution for residency training. Additionally, students in the low exposure group would consider themselves more likely to donate to the school as alumni in the future. Additionally, when we asked about missing class, students in the high exposure group, approximately 27% reported that they've missed class, compared to about 3% in the low exposure group. Additionally, medical students in the higher exposure group were more likely to consider medical school transfer and more likely to consider withdrawing from medical school. So ultimately, from our quantitative data, we were able to identify that the frequency of microaggressions is both common, seems to have influence on well-being among medical students, and additionally influencing medical school satisfaction.
Before I begin, I want to say thank you so much for the warmest welcome I could ever have asked for. I really, truly appreciate being home. And the second thing that I want to say is to the students who actually participated in our study. I really thank you, if you're in the room, for being courageous, because I realize telling your story is not easy. And also reliving your story can be quite triggering. So again, I thank you for your courageousness. I want us to pivot now to our second part of our study, which is the quantitative, which is where we actually interviewed students. We did not expect to actually have such similarity in our themes as what was just discussed, but you'll see in a moment, quite honestly, there were quite similarities. 37 students, both institutions, medical students, nursing students, and PA students, who self-identified as African American Black, Latinx, Native American, Indigenous. And what we were asking them to describe is what were their experiences of microaggressions in their own words. Then we explored what was the emotional impact, and then lastly, help us understand how our institution could be better. How could we create a more inclusive environment and one where everyone feels they belong, including those from historically underrepresented backgrounds. Our findings were actually not surprising, but sobering. First and most importantly, as Dowin just showed you, these was not one of those, let me think about that. Now let me dig something up from someplace in my educational experience. That was quite the contrary. Each and every student that we interviewed had multiple experiences, and quite honestly, we had to cut them off for time. So that happening daily, I think our data would support. Unfortunately, they described it in all settings, be it clinical, be it the classroom, be it curriculum, and quite frankly, be it in the hallway or in the cafeteria. And then what I really, especially as educators and leaders of our institutions, want you to pause and think about is that it had impact. It is not something that just happens and you just brush off and keep walking. Just listening to some of these students, they actually started crying and being in tears to even retelling the story again. True impact. And then lastly, thoughts about what can we do differently. And they really said we needed more diversity on all levels, student, faculty, and staff. We need a much more diverse environment as a whole. We need to really think about our curriculum. I'll use the word curricular reform and stop using race as a biological construct and start having honest conversations about the social determinants and the structural isms, and I'll let you put isms that actually lead to certain communities having poor health. And then lastly, really talk about how do we create spaces that are safe, could be facilitated, but more importantly, allow for real, true conversation. I'm going to actually put a couple of their voices in the air. I want to be very clear, this is not the majority by any means. We had to pick out samples, but to kind of bring home some of the points. So the first one, and I'm going to put all the voices in the air for the moment, was around isolation. Now, I'll be the first to say, if you look at Adal, they don't necessarily talk about isolation as a microaggression within itself, but some of the scholars now are really starting to think about this in this way. If I'm the only one, and I'm always asked to represent, and I'll let you again fill in the blank, that within itself is a microaggression. I stand out very quickly in a classroom full of people who don't look like me. I have found more and more that in whatever space that I occupy, whether it be in a class, in clinical, or when I'm attending a conference, the voice of minorities is missing. If you don't walk that walk, it is very hard to relate to how isolating it can be, being the only one, ever how you define that. The second theme that jumped out quite often was a theme of devaluing and discounting, and although we didn't label it this way, quite frankly, voices being completely unheard. People would not respond to things that I say in the classroom. Even if I said something that someone else said after me, they respond to what the other person said, even if it's exactly what I just said. They would not acknowledge that I had contributed anything to the discussion. Educators in the room, I'm speaking to you. There is great data out there about unconscious bias, and as educators, unfortunately, we play into this. We acknowledge certain people in the room quite often and not others. And these quotes actually, unfortunately, suggest that we have gotten no better at that. So as educators, I actually would really encourage us to be much more cognizant of how we are managing our classroom and making sure that we really, truly are actually acknowledging all voices and actually, more importantly, actually giving praise to all contributions. Assumptions of inferiority. Sometimes in a study group of 4 or 5 of us, I won't get asked a question. I won't be asked, what did you get on this question? What do you think about this? I'm not the go-to person. Sometimes this upsets me because I do know the answer. I do have something to contribute. I can explain it well. I don't understand why students don't see me as having equal knowledge on a particular topic. Frustrating, because it makes me not want to participate in the group. I feel like if no one thinks I'm going to bring anything of value, quite frankly, why speak up? The last 2 that I'm going to present are in the clinical setting. And again, we actually looked at microaggressions and we saw them again, classroom, clinical, and in the hallway. If someone who's both white, male, and excited about the new patient, or if it's a surgery, they get it. I won't even get a shot. But I don't know if it's intentional. It's kind of like they assume the other person is more like ambitious or wants it more or something. And they will often get it without really asking me at all. The invisibility factor. It's like there is this thing of being invisible and a high visibility as a person of color. You know, you're passed up for the opportunities a lot, and sometimes there is a simple magnifying glass looking over you. And I actually really want to get us again to pause on this one, because minority communities say this a lot, especially underrepresented in medicine. When it comes to knowledge and intellect, can be quite invisible in the conversation because people don't even assume that the important thing is going to come out of their mouth. But when it comes to deviant behavior or criminality or something negative, always looking at very specific people in the room. So yes, we can be invisible, but also actually under the microscope, literally simultaneously. Thank you so much.
Good afternoon, and thank you for being here and letting us share these very humbling and very powerful stories from our students. I'm going to present reported experiences of microaggression within the curriculum. As a clinician educator, I felt not only humbled, but I learned from the experiences that these students had, each of them bringing their own social experience before and during the school as experts. So the first curricular microaggression that we would like to describe is what we call teaching about race as a biological inferior construct. There are other microaggressions, like in lecture. Maybe they'll talk about a disease, and then the next thing they say is the ethnicities with the highest incidence. And I'm thinking, wow, I'll be the one to ask, so what is it about this ethnicity that makes them that way? And they point to genetics. And I'm like, well, aren't we 99.9% similar? So is it genetics that's making the change? And that's then when me and the lecturer are at a standstill. Like, okay, the teacher says, it's not genetics, but I don't really know the reason, so let's move on. Another example of this is coming from another student who said, one lecture we had last year, we were discussing iron deficiency. And the lecturer said, patients, for most of these people that have this deficiency, they have kinky hair. And that's like a marker of disease, kinky hair. And I was like, I think there's a whole population of people that have kinky hair naturally. So to use that as a marker, kind of rubbed me the wrong way, kind of made me think. And for the educators in the room, I hope that that student had the courage to put that in an evaluation in a constructive way, because perhaps the person that was teaching about this didn't mean it in this way. But that's what we got. So what I'm going to show next is a word cloud of the types of emotions that were represented in our qualitative data. And this is qualitative data, and the words represent the most common emotions that were displayed. And probably you see there, big and central, the word anger. And we don't want angry students, right? We don't want angry students in our classroom, unless that makes them, contribute more. But that may not be the case. So anger, sadness, doubt, frustration, awareness, being uncomfortable, negative, surprised, afraid, anxious. These were the many emotions that were reported by our students as a result of experiencing microaggressions. And I'm going to illustrate some of these emotions in the way that the students courageously presented it to us. Students speak about stress and anxiety. For me, I had to go on anxiety meds and for depression as well because of the stress that we go through, having to go through therapy when I never had gone to that before getting to the health professional school. So I feel I don't know if it's a consequence of being in school in itself or the microaggressions and being anxious. Another student said, "You are performing and you are always stressed. How are you going to learn?" That's not the ideal way to learn. I'm a curious person. I enjoy learning at one point. But when you are learning and you are feeling like you are already expected to fail, that is not a good feeling. This was to represent the stress and anxiety that microaggressions had on the students' experiences. Another thing is feeling that they are not getting the whole experience, which we call divesting in this course. Yes, this had an impact on me academically. In the past, if I had questions, I would have just raised my hand. I wouldn't have thought twice about it, and I would have sought out the answer. Now I think twice. In fact, every day before I go to school, I look at this thing I wrote for myself that says, "Please the teacher, melt into the metal, stay silent." I try to look at that and read that every day before I leave the house to remind myself to keep my head down and keep my mouth shut, not to draw any attention to myself. Last one is on the effect, the extra burden that these microaggressions have on the students' experience, which we call the diversity tax. The thought has come up a lot for me. What are all the other ways that students of color are being pulled away from their studies because of psychological impact or anxiety? But they are the ones who respond whenever something happens, which show up. I feel like I've had to be a student and an advocate for myself when I should have just been focusing on studying. And I feel like that's been the hardest, where I often feel I just want to study, but I don't have time to study because I'm going to all these meetings about things that are going on and things that are wrong and things that I want to change, organize for ourselves, that the school is not doing for us. So we just wanted to share a few of these things and then bring some discussion around these examples, which there were many more.
All right, so the next group of questions that we asked students was around, what do you think needs to happen so that we can move towards a more inclusive learning environment in our respective institutions? So they came up with some great ideas. I don't know that any of them will be shocking ideas. They make perfect sense, but I thought we could go through them one by one. So the most resounding result that we got from all of our students, pretty much every student had a comment around this area, is that we need more diversity. We need more students. It's, as you have heard from some of the microaggressions, it's really hard to be the lone student in a classroom. It is really hard to represent your entire race in a classroom setting, in a clinical setting. And the stress of that actually takes energy away from learning and being able to perform to dealing with that isolation. They want to see more faculty of color, and this is considered a microaggression when they come into an institution and see that there's nobody else like them on the faculty. This suggests to students that we do not value we don't value diversity to the degree we say we do. Of course, we need more staff of color as well, and a big bid for leadership. Students are acutely aware of the demographics of the leadership at both of the universities and feel like it's unfair. And how can it be that people who don't have similar backgrounds to them are making major decisions that impact their lives about resource allocation, about the curriculum, and so on. We talked about this already. So there is a sense of a hidden curriculum. So when we're teaching students that there is a genetic predisposition to things like cardiovascular disease, diabetes, obesity, there is an underlying thing that we're implying, and that's that there's biological inferiority. And I'm not convinced that, well, I don't know. Do faculty mean to say that? Because you understand that if we don't teach about social determinants of health and teach it well, the alternative thought is that there must be something wrong with people of color. And this has come up over and over again. And so when you look at the science, we see that 20 to 30% of health issues are related to genetics. 70 to 80% of them are socially related. When you compare people that are within race and without race, there's the same amount of genetic difference. So if you were to look at a group of white folks and black folks, there is the same amount of genetic difference within groups, which is another indicator that people of color don't have a higher risk necessarily for cardiovascular disease because of genetics. There's something else going on, and we need to teach that. Students really want opportunities for open conversation. So we saw a couple of statements by students where there was an attempt to have a conversation, and it appeared that the faculty member didn't know how to have that conversation and wanted to move on in the topic. So I think it's really important for faculty to realize that students want to have this conversation. And it's hard for faculty because a lot of us didn't learn having this conversation, so we're having to develop a new skill, but that doesn't let us off the hook. We still have to learn how to have these difficult conversations with students. Safe spaces. This is also in the literature called counter spaces. So this is an area where you can come and talk with people that are similar to you. And let me just give you an example. In this picture here, I don't know if you can see it very well. Jan Marie Garcia is over here. Melanie Turvalon is here. There's me. I really like that picture because those glasses I can't find are there, and I think if I stare at that picture, I'll find the glasses. We were doing a Train the Trainer for Cultural Humility, and it was so nice to be in a place with people who understand the context of and the impact of racism. We didn't have to convince anybody that we were having this experience, and that felt like a safe space for us to be able to talk about our own experiences. And although we learned wonderful content, I think the thing that we took away from it was this sense of safety. For 2 whole days, we got this sense of safety. Students want that safety, and we can provide either formal or informal spaces for students to have that. With that said, the literature is also showing that having conversations across groups is also very beneficial. So that if a student is feeling like they're having a microaggression from a faculty member, take, for example, student sends a faculty member an email and doesn't get a response, and they think, oh, they didn't respond to me because they don't like me, or they don't like people from my group. There's this whole sort of inner narrative that's happening. And then they come to this group and they're with all sorts of different students, and they find out, oh, that faculty member doesn't really email back that often at all. It's not really about me, it's about this professor. And that can be very healing and can recontextualize the information that the student has been taking in, okay? So we need safe spaces within group and out group as well. So another thing that came up that is more of an interpretation of data that came in. The students were talking about the diversity tax. So this is the sense that it is expected of people of color to deal with diversity issues, to deal with health disparities based on race. And this is, I don't know if people have heard this term before, but this is something that's commonly talked about amongst folks of color. And this is an additional burden for folks. And there's this powerful part that white people can play in mitigating some of these diversity issues. There is a scholar named Dr. Jonathan Paul Higgins who said that moving allyship to activism is about looking for ways that you, as a person in a privileged position, can truly uplift the voices of those who are often out on the front lines of change. So this means people of color should not be the only ones that are working on diversifying our student, faculty, staff, and leadership. This needs to be something that's done organizationally, and everyone needs to have buy-in. There's a spot for everybody in this. The greatest thing that an ally can do as a form of activism is building their own capacity to receive criticism, specifically when said criticism is coming from marginalized people on your campus. So we just had this beautiful sort of list of things that students from our institutions have told us. Our students were very brave. We've tried very hard to remove anything that would identify our students, but a lot of students were interested and came forward and gave us this information. So the next question is, what are we gonna do? Are we just gonna listen and think that this is interesting, or are we gonna make active changes in our organization to mitigate microaggressions? And I just wanna put a plug in there. I know that a lot of this information doesn't seem particularly uplifting, but I just want to go back a little bit, that I feel like having this conversation for the last 15-ish years, that I've been trying to convince people that diversity is important. And one of the things that is really nice about being here at UC Davis is I don't feel like I'm trying to convince people that diversity is important. People are saying, how do we move forward? How do we do this? And this is one of the reasons that we wanted to ask students what their opinion was about how we could move forward, right? So this is actually a gift that we've gotten. We have the desire, we talk about the mission, now we have some information about what we can do to move forward.